So today I'm going to talk about the lessons learned from our measles response project in the Katanga region in the DRC in 2021-2022. So many of you are very familiar with the context of measles in the DRC. The DRC faces recurring measles epidemics, as you can see here based on the historical data. The largest historic epidemic so far occurred in 2018 to 2020, with more than 7,800 reported deaths. And there is another epidemic ongoing since 2021. The reason for these recurring epidemics is mainly due to low vaccination coverage throughout the country. And as you can see on the map, in many areas of the country, the 3-year intervals of supplementary immunization activities is insufficient to prevent these epidemics. In addition to that, many areas have difficulties in access to care, resulting in a high case fatality during measles epidemics. So MSF introduced a measles emergency project, the OJEPI project, in 2018, and we currently revised the strategy in 2021. So the project covers the 4 provinces of the Katanga region: Haut-Katanga, Haut-Lomami, Lualaba, and Tanganyika. The objective of the project from an epidemiological view is to improve strategies of prevention and response to measles epidemics. And it includes several types of activities, such as preventive vaccination activities, a surveillance component, biological confirmation of epidemics, interventions, including vaccination and case management, as well as operational research. OJEPI uses a targeted approach, meaning that we allocate more resources towards high risk, or what we call priority health zones. So now during the next minutes, we'll talk about what have we learned from our activities in the last 2 years. So I'll start with talking about whether we managed to select the right priority health zones and what impact we had with the preventive activities that were implemented in some of these priority health zones. In the second part of the presentation, I'll talk about how we tried to choose the most pertinent alerts in the context that we were facing many simultaneous alerts, and what impact we had with our interventions during measles epidemics. Okay, so as mentioned, OJEPI is based on a risk-targeted approach. So even though the project covers all 68 provinces in the region, we divided them into non-priority and priority health zones. The non-priority health zones, there are about 48 of them. So we have in all of the 4 provinces existing MOUs in place between the MSF and the Ministry of Health to allow for smooth collaboration during surveillance and intervention activities. Moreover, we have surveillance at the health zone level based on the national surveillance data, and then using this data we detect alerts, and we may decide to investigate these alerts and intervene. In the priority health zones, which are about 20, we have the same activities in place, plus some additional activities, such as preventive vaccination in some of the priority health zones. We have an enhanced surveillance that allows us to intervene more rapidly, using data at a smaller spatial scale or line list data where available. We may also decide to provide support for outbreak investigations and biological confirmation of epidemics, and the priority health zones are slightly prioritized for interventions. So how did we select these priority health zones in 2021-22? So the basis of our selection is a model-based risk ranking that combines information on vaccination coverage, the estimated number of non-vaccinated kids, the estimated number of susceptible children into a final prioritization ranking. In addition to this ranking, we also took other criteria into account. So in 2021, we decided to focus on the Haut-Katanga province for logistical reasons, and we combined the model-based risk ranking with an alternative risk analysis in Haut-Katanga province. So in the end, we selected 21 priority health zones, of which 11 were from Haut-Katanga, and the others distributed across the other provinces. In 2022, we decided to choose 5 health zones, again based on the model-based risk ranking per province, due to collaboration reasons. And we excluded health zones that had already experienced large epidemics or had recent vaccination campaigns. So in the end, again, resulting in 20 priority health zones in the beginning of 2022, which we then revised to 9 health zones mid-2022. So now, after 2 years of activities, we can ask ourselves, did we prioritize the right priority health zones? So we can use 2 measures for that. So first, the proportion of health zones that experienced large epidemics, as in at least 500 cases. Or we can also look at the median size of epidemics. So here you can see where we compare the proportion of health zones that experienced large epidemics in priority health zones against non-priority health zones. And so here we compare each time those prioritized in 2021, or those prioritized 2021 to mid-2022, or those prioritized 2021 to the end of 2022, each time comparing them to the zones that had not yet been prioritized at the time. And you can see that the proportion of health zones with large epidemics was higher in the priority health zones in yellow than the non-priority health zones in blue. The difference, however, was less pronounced in 2022 than 2021. Similar for the median size of epidemics, which is indicated as the middle line of the boxes, we can see the median size of the epidemics is higher in the priority health zones than the non-priority health zones. In 2022, the priority health zones also included smaller epidemics, which made, again, the difference less significant. So as mentioned before, we introduced preventive vaccination in some of these priority health zones. But before looking at what impact we had with our preventive activities, we need to look at what happened in the priority health zones that had not been vaccinated through preventive vaccination. So here you can see that occurrence of epidemics was extremely likely in priority health zones that were not vaccinated, with 9 out of 10 unvaccinated health zones experiencing a large epidemic. Preventive vaccination had been implemented in 9 priority health zones in 2021, and here you can see that preventive vaccination probably averted 6 epidemics out of the 9 vaccinated health zones. The epidemics that occurred in the 3 remaining health zones were likely due to low coverage, such as in Kilwa, where vaccination was selective based on vaccination cards, and Kinkonja and Manono, where vaccination coverage surveys actually demonstrated low coverage. So now we can see that our prioritization worked, but we still ask ourselves if there would be simpler and better ways to select these priority health zones. So we've been looking at alternative prioritization approaches, such as just using a model-based ranking without any logistical or collaborative criteria. We also compared it to a vaccination coverage ranking, where lowest coverage would represent the highest priority. And for each of these approaches, we look at if choosing the top 5 health zones by province would be a better approach, which is close to what we used in 2022, or if choosing the top 20 health zones in the entire region would be a better approach. In addition, we looked at another simple threshold criterion, choosing health zones with vaccination coverage below 40%. And this is based on an analysis of historical data, which looked at characteristics of health zones that experienced very frequent epidemics. So now, again, using the measure of the proportion of health zones that experienced large epidemics, comparing priority with non-priority health zones, we can see that in general, both for the model-based and the vaccination coverage-based approach, the top 20 approach works better than the top 5 approach. We can also see that the top 20 vaccination coverage approach slightly outperforms the model-based approach. However, the last approach that we chose based on the 40% criteria showed a more pronounced difference in proportion of health zones experiencing large epidemics between the priority and non-priority health zones. And it also outperforms the actual selection from 2021. So using this simple threshold criteria may be a simpler and more efficient selection option. So the summary of part 1. So we can see that prioritization in the last 2 years worked, especially in 2021. However, we can replace it by a simpler and more efficient selection method, just using a vaccination coverage of less than 40%. For the impact of preventive vaccination, we can see that there was a clear impact of preventive vaccination with probably 6 averted epidemics. However, in some areas, improvement of vaccination coverage may be needed to have a better impact of preventive activities. Now moving on to the second part of the presentation, how well did we choose our alerts for investigations and interventions, and what impact did we have with measles epidemics interventions? So just as a reminder, I think many of you have seen that last year during the presentation. So the WGEPI alert system uses alert thresholds that were chosen to balance positive and negative metrics. So we want to maximize the patients captured by interventions, meaning we need to detect all outbreaks and we want to detect them as soon as possible. We also want to minimize the risk of false alarms to reduce the workload. So for WGEPI, the non-priority health zones, we chose a very balanced alert threshold with 20 suspected cases per week or 35 cumulative suspected cases per week, per 3 weeks, or 3 confirmed cases in 4 weeks. For the priority health zones, we opted for a more sensitive threshold, which allowed us to detect alerts earlier, with 10 suspected cases per week, or 15 cumulative suspected cases in 3 weeks, or 1 confirmed case. However, as you can see, particularly during the epidemic phase in 2022, the alert system resulted in a large number of simultaneous active alerts, so much more alerts than we were able to operationally deal with. So how should we choose among all these alerts those that we should investigate or intervene? So fortunately, we had introduced an alert scoring algorithm, and this algorithm was based on our understanding of risk factors of large epidemics. So the algorithm includes indicators of epidemiological tendencies, such as the number of cases, the tendency of cases, the case fatality, and whether the epidemic was biologically confirmed. But it also included indicators of the epidemiological context, such as whether the zone was a priority health zone, the timing and size of the last epidemic, the vaccine coverage, and whether there were neighboring epidemics. So each of these indicators had a certain score allocated to it, resulting in a total score that theoretically ranged from 0 to 16, and alerts were then just ranked according to this score. For the final decision, we of course took also other criteria into account that could not just easily be integrated into this algorithm, such as whether we were too late for an intervention, and other logistical aspects, the security, and the presence of other partners. So again, we ask ourselves, did this alert scoring actually work? So can they identify potentially large epidemics? And to assess that, we again use the 2 metrics, similar metrics than before, the proportion of health zones with large epidemics, or the median size of epidemics. So here you can see that the proportion of health zones that experience large epidemics increases with the alert score. So even though we recommend the use of the score on a continuous scale, just as an indication, a score of at least 11 would have kind of a balanced sensitivity and specificity to detect health zones with large epidemics. A score of at least 13 gives an indication for an almost certainly occurring large epidemics. And similarly, the median size of the epidemics also increased with our alert score. So this is good news. The alert score guided us in the right direction. So did we in the end make the right intervention decisions, or were there any health zones where we should have decided otherwise? So among the 68 health zones in the Katanga region, MSF actually vaccinated 21 health zones during 2021-2022. There were 12 health zones where MSF decided not to vaccinate that experienced large epidemics. Unfortunately, among these, 6 health zones had been vaccinated by the Ministry of Health, leaving 6 health zones with large epidemics, but no large-scale vaccination. So should we have decided for these health zones differently? So 3 of the health zones actually had very atypically long and flat epidemics. So at any moment in time, it would have been difficult to make a different decision. However, alert scores were quite high. Now, knowing we can trust the alert scores, we could make a different decision next time. In one health zone, however, the alert score actually increased quite late in the epidemic, which was due to an unusual progression. And in 2 health zones, the decisions were based on the assessment of MOH capacity and partner positioning, so difficult to make different decisions the next time. Now, regarding the impact of our vaccination campaigns. So first we can look at what happened actually 4 weeks after the vaccination campaign, so leaving some time for the vaccination to take its effect. So here you can see the number of cases before vaccination and after vaccination, 4 weeks after vaccination. And in general, we can conclude there were no persistent epidemics after vaccination, so case numbers were generally small. Also to add, based on the surveillance data, we know among the health zones, the few that actually obtained biological samples, the notified cases after vaccination were mainly measles cases and not predominantly rubella. So did health zones with MSF vaccination experience smaller epidemics? Unfortunately, the epidemic attack rate was 3 times higher in the health zones vaccinated by MSF than those vaccinated by the Ministry of Health or the non-vaccinated health zones. So it is impossible to measure our impact based on case numbers or attack rates. Well, first of all, because MSF was really trying to target the health zones with larger epidemics, but also the free case management offered by MSF attracts cases to the health centers, which are then included in our surveillance numbers. We do, however, see a very strong impact on the duration of epidemics, where the duration in MSF-vaccinated health zones was about half as long compared to non-vaccinated health zones. Based on an analysis of historical data, we observed that about half of the number of cases occurs before the peak and half of the number of cases after the peak. So now, assuming this observed symmetry of the epidemic curve, we can conclude by reducing the duration by half that we may have averted about 50% of cases through MSF vaccination. Now, looking at the vaccination delays, here since the first week where 20 cases had been notified in a week, which is an indicator of the moment when an epidemic really takes off, we can see that vaccination delays were generally much shorter for MSF vaccination than those by the MOH, which were sometimes a bit disconnected from the epidemic progression. MSF vaccination in median took place after 8 weeks after 20 notified cases, which is about 2 weeks before we would expect the epidemic peak to occur, based also on historical data analysis. Also, we observed that attack rates during MSF vaccination increased with the vaccination delay, so this means that earlier interventions will have a bigger impact. So in summary of part 2, we could see that the epidemic size increases with the alert score, and the score successfully guided us in efficient intervention decisions during the last 2 years. For the impact of MSF reactive vaccination campaign, we could see that epidemic size is not a good indicator for the evaluation. However, we could demonstrate a reduction in the duration of epidemics by 50%, where interventions with shorter delays will have a larger impact on attack rates and case numbers. So in conclusion, the risk-targeted OGEPI approach, including preventive and reactive activities, allowed to help avert or limit the scale of measles epidemics in several of the health zones in the Katanga region during 2021-2022. Preventive vaccination in identified high-risk health zones is a powerful strategy, particularly in health zones that are difficult to reach during reactive interventions. Our alert scoring helped us to make efficient intervention decisions. And in general, we should still try to keep delays in vaccination campaigns to a minimum to further improve our impact. So even we didn't go into details, but in some places with low vaccination coverage, we may also need more locally adapted strategies to improve our impact of vaccination campaigns. So I would like to thank particularly the two epidemiologists based in Lubumbashi, Alidou and Charles, who are running the entire epidemiology component of the project. And of course, the entire OGEPI team, with only some names named here, as well as our collaborators from the Ministry of Health, in DRC, the INRB in Kinshasa, and the Grand Laboratoire de Lubumbashi. And thank you very much for your attention.